Hello and namaste. Good afternoon or good evening, wherever you are, and welcome to the fifth webinar on mental health policy and practice in India and how it can actually promote mental health literacy in India. It's a great pleasure to have you all with us. This program is also streamed live onto MeHeLP Facebook page, so hopefully you can join. The structure is that we normally have a discussion for about 40 minutes, and then there's an opportunity for attendees to actually ask questions and engage in a vibrant discussion about mental health policy and practice. So we have two distinguished guests in this webinar, Professor Joe Thomas and Professor Asha Soletti. I'll introduce them both in a minute. But let me just say that I have great pleasure to actually have you all with us. And I'm Raghu Raghavan. I'm a professor of mental health at DeMontfort University in Leicester in the UK. And I lead a project called the Mental Health Literacy Project in urban and rural in Kerala. This is actually a UK Research Council funded project that started in September 2018. And this will be going on till October, the end of October 2021, that's this year. This is actually a project to actually promote mental health literacy in urban and rural communities. And you might actually ask why Kerala, because Kerala is, according to the Mental Health Survey of India 2017, Kerala has got a higher percentage of prevalence of mental illness and suicide rates. And that's the reason why we chose Kerala. But the principles and the work and the messages that we gave is applicable to all other Indian states as well in terms of practice and further development of mental health literacy. So this is actually an international interdisciplinary project that actually explores mental health literacy using theater, creative arts, films, and a variety of methodologies that we can actually engage with communities, hear their voices, and how we can actually then promote that understanding of mental health literacy. And there are a number of partners in this project from the UK. We have colleagues from DeMontfort University in Leicester. We also have colleagues from Latur University, which is also based within the Leicestershire County. And we have colleagues from University College London and also Middlesex University. We also have theatre partners from the UK. And from the Indian context, Professor Asha Soletti is actually leading as a key PI from the Indian context. And we also have other partners from the Tata Institute of Social Sciences and also from NIMHANS. And we work with two NGO organizations in Kerala, and also the MeHeLP Foundation, which are based in Calicut and Ernakulam respectively. We also work with theatre partners in Indian context. We are working with a theatre group called Logadami based in Kochi in terms of our theatre and other activities as well. So it is actually truly a creative arts oriented program, how we actually explore mental health literacy. This is very much of a mixed methodology research and engaging and storytelling and developing together a program and awareness as to how we promote mental health literacy. So you might actually ask, what is mental health literacy? Mental health literacy is much more than mental health awareness. It is not mental health awareness in the truest sense of the word. Mental health literacy is actually very much of a Western concept. But we want to finally explore how that can be promoted within the Indian context using the social, cultural, religious, and other normalities. So it consists of 6 different components or 6 different arms. First of all, it's actually our ability to recognize specific disorders or different types of psychological distress. Secondly, mental health literacy is about knowledge about risk factors and the fact and the risk and the causes or triggers that might be actually affecting us. And thirdly, it's about the knowledge about self-help interventions, what are the kind of things that we can actually do ourselves in terms of both promoting mental health and well-being, and also in terms of anxiety, depression, and other mental distress or mental conditions. And fourthly is actually about knowledge about professional help that can be actually accessed so that you can seek a professional help and support when required. And fifthly is looking at attitudes which facilitate or promote help and recognition of distress and illness. So this is more about how we eradicate the stigma, how we overcome the stigma connected with mental health or mental illness. And finally, it's actually knowledge about how we seek mental health information, because this is an area that people don't know much about. How do we seek the right kind of information in terms of promoting mental health literacy? Because why we require mental health literacy? Low mental health literacy is always associated with more stigmatizing attitudes, and which in turn prevents people from accessing mental health services or help and support. And hence, mental health literacy is a key in terms of creating that well-being, creating that happiness, creating that personality development of individuals. So today, our focus is actually on mental health policy and practice, and how mental health policy and practice focuses on mental health, promotion of mental health literacy in the broader pan-India context. Because it's a topic worthy of discussion as how policy is actually tuned into that. So we have two distinguished guests with us who would actually promote the discussion in relation to this. So let me warm welcome to Professor Asha Banu, and she's a colleague and also a co-PI, as I said, for the MeHeLP project in India. Professor Asha Banu is a chairperson at the Center for Mental Health at the School of Social Work at the Tata Institute of Social Sciences in Mumbai. She has got extensive experience of field engagement, both in urban and rural context, in terms of action projects and other research at community level interventions. She's actively contributed to many of the disaster relief from the Institute's perspective, both right across the country. And she's also a member of Institutional Review Board for the organization of courses within the Indian context. So very much welcome, Asha, to this webinar, and great to have you here. We have Professor Joe Thomas, is Associate Dean of the Faculty of Sustainability Studies and Head of School of Public Health at MIT World Peace University in Pune. He's Professor of Public Health and Sustainable Development, and he has extensive international public health experience. He has actually worked with health-related issues in India, East Timor, Australia, Bangladesh, South Africa, Nepal, and Hong Kong. Professor Thomas has carried out consultancies in Mongolia, China, Indonesia, Thailand, and Uganda. His research and teaching interest is in the area of human rights, structural determinants of health, health diplomacy, human security, and health policy. So a very warm welcome to you, Professor Thomas, to this webinar, and thank you for coming and supporting the MeHeLP India project. Great to have you both. So the discussion around, we would in this, but we are taking a short deviation in the normal structure that we follow in this webinar. We have a short presentation, both from Professor Asha Banu and Professor Joe Thomas in relation to health policy and mental health policy in India, which I think will actually help us to actually pitch our discussion on how the mental health literacy angle could be taken from the health policy dimensions. So first of all, then, can I ask Professor Thomas to say a few words in relation to the health policy and mental health policy in the Indian context?
Thank you, Professor Raghu Raghavan, and also I'm glad I'm with Professor Asha Banu. And also let me thank all the people who are working behind the scene and putting it together. And let me thank particularly for inviting me to this session. And let me connect my anxiety level to the mental health literacy. I'm since you're working and you're talking among the friends and colleagues, so I'm not particularly anxious about what I'm going to talk about it. My association or understanding about mental health began with my work with refugee children in Vietnamese refugee camp in Hong Kong, way back. So the understanding about mental health and also the responsibility of the institutions, government, and also the stakeholders. So this is the one, that gap, that's what I've noticed. And when you look at, again, from a national point of view, even the context of Indian policy, and we have written policies, but at the same time, translating these policies in action and also coming out with certain program of action. That's one of the difficulty there. So from that context, applying the health literacy concept, and most importantly, our capacity to understand and distinguish the spectrum of mental health issues, because mental health, we are talking about a spectrum of symptoms, diseases, and also conditions. So quite often, understanding and distinguishing is from a pedestrian point of view, it becomes very difficult for the people. So mental health, the moment it's classified as any form of mental health, and immediately stigma set in. So we don't have a system to deal with the main determinant and consequence of mental health, I would say the stigma. And addressing the stigma, the policies, I would say that that's mostly, that's one of the major dilemmas of the policy making. How do we come out with a significant program of action for addressing the stigma associated with mental health? Second issue I noticed that mental health policies are, within the mental health, we have our overall framework, but there are specific population groups are left out of it. Children are left out, and also adolescent young people are left out, and quite often elderly population is left out, ethnic minority population is left out, because the interpretation of mental health, also there are cultural dimensions associated with it. And also quite often in many of the traditional societies, mental health is considered as that's linked with religious practices, or certain religious practices may contribute towards and also preventing and also treatment. So the understanding about mental health as a disease, and that particular element is missing from the overall policy framework and also popular discourse, even I would say the popular media and the social media. But at the same time, I would like to emphasize, number one, the need for strengthening our health literacy, mental health literacy, from an action point of view, from the prevention point of view. And also we have to look at in the context of not only national policies, we have other larger obligations. For example, mental health is one of the major targets and indicator in the Sustainable Development Goal. SDG 3 is specifically looking at the issue of reducing mental health related debilitating condition, and also reducing the suicide among the adolescents. So we have a global obligation rather than, on the top of the policy obligation. And then we have a WHO's World Health Assembly got a huge commitment created by the other members of the WHO World Health Assembly. And there is another dimension of the responsibility and the national task, the national responsibility to act on the mental health. So national policy, we have a global obligation at the World Health Assembly, at the UN General Assembly, there are two layers of it. But at the same time, when you look at national level, again, I would say that probably we have to have a health literacy program addressing on the institution level. For example, any education institution, universities, colleges, they should have a strong mental health literacy program. And not only mental literacy program, and an action program. How do we deal with mental health issues and a mental health, an education protocol and also action protocol. Probably a comprehensive literacy program, mental health literacy program, focusing on institutions. And particularly looking at the institutions related to the education, universities, schools, +2. So the entire education spectrum should have a very strong emphasis on the mental health literacy program. And this should be policy-wise, and also we should have explicitly allocated resources. We have a line item resource allocation for strengthening the mental health literacy for the adolescent young people in the education setup. I would say that is one of the priority issue, because diagnosing, identifying the spectrum of mental health issues among the students and the peer groups, the children, and the children who are affected by the mental health issues. So that support system is very less. And always, because when the mental health stigma sets in, they cut off from their peer support, they cut off from the treatment option, and their own understanding about what's happening to themselves, that self-learning opportunities are lost. So in nutshell, we have to look at the mental health, the policy issues, and in mental health education, the strategies or initiative should be initiated on a different levels, national policy, state level policies, and also institutional level policies. And institutional level policies, I would focus more on the mental health literacy program. And national policies should focus more on institution building, capacity building, and resource allocation. And also we have to link up this with the national disease burden. If you look at the disease burden, a significant part of the disease burden is derived from the mental health related issues. As you mentioned in your introductory remarks that Kerala got some remarkable health indicators, achievement in the area of health, but at the same time, Kerala also demonstrating very high level of mental health issues, mental health challenges, and also all spectrum of mental health issues, particularly among the adolescent and young people. And I would also emphasize the issue of mental health issues in the context of the current scenario of a global pandemic. In fact, the global pandemic is putting adolescent and young people in a very disadvantaged position on various levels. One is the physical and infrastructure, the context in which the mental health are exacerbated is all working in the COVID settings, because you're confined, you don't have your peer support, you don't have physical mobility. That restriction and education setting, quite often that peer support is an important safety valve for dealing with the mental health issues, but that is lost. And also we could see that one of the side effects of the lockdown is violence targeted towards, mostly what we call it as domestic violence. And adolescent and young people are more at the risk of violence. And this violence is also related with what they call it as truants, tantrums, which quite often it's an exhibition of mental health related challenges. So, and many of the parents, they don't even understand that. I had a webinar, I was talking to the parents of children about mental health issues. When I raised this issue, parents said, we are there to support them. Then what is the mental health issues you're talking about? So parents' understanding about what is a symbol of signs of mental health for children is very, very low. I'm talking about university students and the +2. At different context, I talk to the parents of children who are under lockdown. So this is what I noticed. So in nutshell, the mental health issues are, we are in a very critical stage because of the COVID pandemic. And the COVID interventions and the mitigation programs are not giving any particular attention towards dealing with the mental health issues of adolescent and young people. And in this context, and also the mental health issues of elderly population. Because COVID pandemic is removed the support structure of elderly population, young population. I'm talking about very specific groups. And also the traditionally vulnerable population groups also left out of in the context of a COVID pandemic. So in nutshell, what I want to say is that probably we have to look at the global mental health policies in the context of the lessons learned and the data and evidence coming through the COVID pandemic. And probably this we have to situate and contextualize in the context of mental health in the disaster setting. COVID pandemic, we could look at it as a disaster setting. So what is the strategy, methodology for intervention in the mental health related intervention in the disaster setting? In the COVID pandemic, we don't have a clear mental health intervention, resource allocation strategies. And also when in the context of many of the research resources are cut down, that is again subsequently going to contribute our lack of our capacity to understand mental health in the COVID period. And that is an opportunity which will be lost because of lack of resource allocation for the research and a detailed and comprehensive study on this. So in conclusion, probably we have to re-evaluate our national mental health policies in the context of COVID pandemic. And also we have to look at WHO's mental health, the action plan. And we have to re-look at with the data and evidence what is happening in the context of sustainable development goal, particularly related to health and well-being. So then the national resource allocation should focus on mental health education investment. That should be a very specific investment, working with creating alliances, creating partnership, and also advocating with for the policy resource allocation for this context. And in this context, I also noticed that there are new technology, new approaches coming up. For example, your approach in Kerala with looking at the looking at the street theater as a new methodology. Probably we have also had to look at what is opportunities provided by social media for the mental health intervention. So new technology, how it can be contributing towards intervention, reducing the mental health burden of the young people, also an opportunity we have to look at it. And I congratulate and thank you for taking initiatives as this. And such initiatives will be contributing towards policy building and also program building and also reducing the burden of mental health in the broader sense. Thank you very much.
Thank you very much, Professor Thomas. I think you outlined very insightful levels of policies that need to be ingrained in terms of sustainable, how we work in a sustainable manner in terms of promoting mental health literacy in young people, in adults, and also in older people. We'll come back. We'll take that up in the discussion point. Thank you very much. Now, can I ask Professor Asha Banu to say a few words in terms of experience and expertise in terms of mental health policy in India for mental health literacy?
Thank you, and good evening, everyone. It's almost going to be similar, and some of the points will be reiterated and would add more to it. Also kind of reiteration, because sometimes as academicians and researchers, certain points we keep reiterating, but then where comes the action and when do we see change is also something very important for us to think of. I'm going to look at from an ecological model. Yes, mental health literacy, Professor Raghu Raghavan has already mentioned. That means it's also about mental health literacy of users. It's also agency of different individuals. So I want to actually, talk using the ecological model, how mental health literacy is influenced by several domains. There are individual factors, as Dr. Joe Thomas mentioned. The individual factors never get captured. Where are they coming from? What is the age group they belong to? Urban, rural, tribal, semi-urban, the linguistic, the language component, etc. That doesn't pay. That's not looked upon. Actually, there is this one core component, and that core component gets assessed often. We do not look at mental health literacy from the point of view of these individual factors as well as the environmental factors. The environmental factors become, what are some of the facilities that are there? What are the situations that they are living in? Are they living in conflict-prone zones? How do you envisage, mental health promotion there? Even when we are talking about treatment management, when we are promoting literacy, as Professor mentioned, it's mental health awareness is not literacy. So, what are some of the mechanisms that are there in terms of, promoting access? So it's not just information. While we are providing information, do they have the resources to access? Do they, if you're talking about health-seeking behaviors, self-help, do they have access to those resources in those, difficult contexts is also something that we need to think about. So this is about environmental factors, and also how does environmental factors also define mental health? Now, when I'm in Chennai, always people say, oh, you should be in Kilpok, because people's understanding of mental health is defined by Kilpok, because Kilpok has the regional mental health hospital. Now, when you're in a particular place, they will say, okay, you have to go to this particular temple because they will do some, chanting and it will become all right. So somewhere, even the contextual factors, be it a hospital or be it a community clinic, so those spaces also define the mental health literacy around that particular context. So alongside personal factors, we also should see that environmental factors also influence the mental health understanding or literacy in that particular context. And the third that comes, the third factor that is very important that we need to look at is the situational factors, which also gets missed out. The situational factors are like, it may be disasters, it may be conflicts. In the current time, it is about COVID. On one hand, we keep talking about COVID and mental health. We keep talking about number of suicides increasing. There are lots of information that are put up of social media. Government also is emphasizing on helpline, but then unfortunately the problem gets exacerbated, more number of suicides. So somewhere, there should be a domain that should define that what are some of those mechanisms that should kickstart alongside disasters or alongside certain situational factors. So there is a situation how a mental health system should respond to that situational factors. So in my understanding, these three domains become very critical. Like we are all aware that mental health is an evolving construct, same as mental health literacy, because things are constantly changing. And then there should be multiple domains and understanding that should keep on contributing. So in order to do this, we need to definitely engage on several factors. So I have listed out certain strategies that I will discuss. And before that, I will also go into a little bit about the project, because where I just mentioned to Professor Raghu that taking pride, that learning from the community is very important. Otherwise, it's like top-down. We have certain specialized tools and we are assessing. And we are assessing, okay, what is school mental health literacy? What is mental health literacy amongst university students? What is the mental health literacy amongst a workplace? But then what? Do we listen? Is there a feedback loop from whatever we are understanding from the context that goes back into? Are we learning? Is there a participatory methodology to collect information from there? Is very important, and that's what mental health literacy project is doing, because it's not like it's like top down. It's mutually informing. The knowledge informs community, and learning from community what goes back to the academic domain, and that's something which I really want to acknowledge. Otherwise, when you look at mental health literacy, there is lots super specialized. People talk about dementia literacy scale. People talk about depression literacy without no resources, without creating multiple resources for help seeking, without talking about it openly to the people and learning about the challenges which feeds back. It's very difficult to promote mental health literacy. So here there are some strategies I've thought and listed, or some of the authors have also reiterating in several papers. The first and foremost is knowledge development. That's what MeHeLP is doing, and collaborating and networking with different stakeholders, and also looking at what are the possible mechanisms and who are the possible actors we can engage as part of the knowledge development. And that way I would credit also, because connecting to doctors, connecting to key players in the Kerala context, there are theater artists who are coming on board. Also, there is dissemination amongst university college students. So we are actually mapping, and there are diverse stakeholders, and you're looking at knowledge development and dissemination. And this knowledge development and dissemination is not, again, something from what we draw from one way of understanding or one developed way of understanding, but again, from a developing context, in a resource impoverished context, what is existing, drawing it from there and giving it back to them. These are certain concerns, these are certain gaps. How do we want to bridge these gaps is what the project is doing. So that way, knowledge development, and what are the methodologies that we are using in the knowledge development, and also is there a funding provision for doing this knowledge development. It should not be we are recycling the same material, but for different methodologies, for experimenting, for engaging with diverse stakeholders, is there an appropriate funding that is provided by the government? So knowledge development is one terrain, and through knowledge development, how are we networking with key stakeholders? That is second. And then third is, how do we raise awareness with the new knowledge and information, and also keeping this as a process-based rather than, it's like one feeds back to the other. So it should be continuously on a loop and not, we are concluding somewhere. So that way, this is very important to understand. So knowledge development, and through knowledge development, who are the key stakeholders we are engaging, networking, and what are some of the new methodologies of capacity building and awareness raising, because we have different stakeholders. What we prepare for a teacher may not be applicable for a warden or not applicable for a police personnel. Nowadays, we've started talking that mainstreaming mental health is very important. But at the same time, are we giving that much emphasis in evolving training materials for specific population that results in whatever we are expecting for, or that results in promotion of mental health literacy? So the context specific, is very important. Otherwise, when we see everything is happening, knowledge development is happening, but is it context specific? Is it capturing from diverse perspectives? Is it appropriate for everyone? Dr. Joe Thomas just mentioned about how he worked with refugees. Here in India, too, people started talking about working with refugees, Rohingya refugees. What are some of the provisions there? Is it context specific? Is it addressing the situational factors? This also becomes critical. And the third dimension is infrastructure. Infrastructure development becomes very critical, because if you're looking at changes, if you're looking at promoting help-seeking behavior, if you are looking at self-help, promoting self-help strategies of individuals, and if you're looking at seeking professional help at the appropriate time, then how do we invest in infrastructure development? And one cannot happen minus the other. All the aspects should happen simultaneously. And I could feel that through this project, some of the aspects are already happening, and it's very organic. Exploring with doctors, exploring with health workers, exploring with media. Somewhere there is so much of a dissemination going on. And definitely, I'm sure, very specific to the Kerala context, the project would be able to deliver some substantial knowledge that can be used over the years. I think this is where I will stop. And I also wanted to say, when we are looking at, this is another, because I also have a tribal project. When we are looking at mental health, sometimes we are also looking at standalone. Maybe we also should start thinking of working on embedded models. How this can be embedded in the school curriculum, how it is part of their, activities of everyday school aspect. So it should not be like somebody goes and takes a session for 2 days and comes back. But then how it is, so in every setting, it should be embedded as part of some of the other interventions. So there can be some change. And this is what I'm experimenting in one of my tribal projects. So I thought that's also one thing I want to talk here about embedded models in specific contexts. So I think with this, I will conclude.
Thank you, Professor Asha. I think that's very in-depth way of actually looking at things in terms of how knowledge should actually make those changes, how individual knowledge, collective knowledge, and how society can actually shape those attitudes, and how it can actually promote better understanding of mental health and well-being, and also about mental ill health and distress as well, really. So, and I think, and the organizational and the infrastructure that might be actually required in order to promote how the policy might actually promote that well-being. So let me open up for discussion, and I think in about 10 to 15 minutes or so, we can take questions from the audience in relation to specific issues about mental health literacy and mental health policy in the Indian context. But before we do that, as we all know, that mental health is not just the absence of mental illness or the symptoms connecting to distress. So, and also the World Health Organization talks about there is no health without mental health. So I think mental health is the key in terms of happiness, sustainability, well-being of individuals, well-being of family, well-being of communities, well-being of the nation as a whole as well. So I think it's important that we focus on that in that context. So I think one of the things is that we have, that from the policy side of things, that I know obviously there are definitive structures for looking at assessment and treatment of mental illness from the whole pan-India perspective, and that at both the state level and also at national level. But one of the questions that I have to you is how, I don't think you may have touched on briefly on that, maybe you want to expand on it. How does it contribute? How can we contribute better personality development of individuals and communities? And how can it contribute to happiness? Because ultimately, mental health is about happiness, how we create that happiness, and how we create that happy neighborhood, how we create that happiness in society, that individuals feel self-sufficient, self-contained, and in terms of, they're actually able to work within the context, etc. They're able to actually work within the stress and strain, and able to try and create that equilibrium whereby they're actually able to create that mental health. So how does the policy relate to that? Can I ask Professor Thomas about that?
Thank you for that very perceptive or probing question into the how to do it. I think probably when you talk about policy, how do we do it? The policy gives a meta framework for what to do, but how to do is the issue. And I mean, there are different experiences coming from different countries, different contexts, even including your the lessons you learned. But also we promoting, when you look at conceptually, how do you promote positive mental health? So that remains as underlying factor. But the promoting mental health among the different role of teachers, how they play the teachers, I think probably the teachers and academicians, education settings, they are the one who playing a much major role in promoting mental health literacy. But at the same time, they're very least equipped with it, to deal with it. And it's an issue of not identifying mental health as a primary public health issue. And also how do you integrate mental health as a primary healthcare issue? And this is almost, there is a huge vacuum because mental health intervention is considered as a specialist intervention. So whether even the counseling level, that support is almost non-existent in the school setting. So one way, I'm not saying the deep professionalizing, there should be different layers of professional intervention for dealing with the mental health issues, because mental health is considered as black and white. Either you are sane or you are insane. So that's the kind of a dichotomy is also creating. And that I would say it's a lack of skill. The public perception about mental health need to be looked upon. And who create that perception change? Academicians, again, play a very key role as researchers, and also the knowledge creator. And if you look at the mental health related knowledge, that knowledge itself is the localized, contextualized knowledge base is very, very limited. And again, I re-emphasize the issue of significant part of the population is left out, even within the children, refugee children is left out. And many of the refugee children, they witness traumatic incidents. So dealing with the traumatic, post-stress traumatic incident, and there is very limited technical input and expertise there. Even the refugees, that stress and strain, that itself is not looked upon that, because when you look at the refugee movement and the population movement, the children's experience of mental health and stress is totally different from the adults and elderly, because children, they lose, because I talked to the refugee children in the Rohingya camp in Bangladesh, and I asked them what you'd like to see. And all of them said, we want to go back to our school, we want to go back to our village. And it is almost out of question in their entire life. They may not even go back at all. But that idea of reconciling with a new resettled context, and even that itself is very fragile, very lucid situation. But there is nobody to guide them that emotional support, because parents themselves is traumatized, and quite often children travel all by themselves. And what we call it as unaccompanied children, that word itself is a little misnomer. Children traveling in the refugee context without parental supervision, without a guardian support. That's also a significant part of the refugee experience. So they left out of that. Then the children with development disorder is almost left out of all the service provision. So I'm just looking at the children who are left out of them, and disabled children, disability, physical disability with mental health issues. So there are subpopulation groups, identifying them, providing support for them, and that in many of them, the program intervention context, it doesn't exist, almost non-existent. For example, even the refugee Rohingya camp, we are talking about almost 1 million population. But at the same time, there is no mental health program addressing them, and particularly for children's mental health, almost non-existent. I mean, when you talk about mental health literacy, but then even in Bangladesh, the general population is a luxury. So in quite often the refugee camp, we cannot expect what is not in the host community. So these are the other contradiction we're looking about. Even if we want to create a mental health program in the refugee context, quite often the administrators of the host population, they may be a bit reluctant or resentful about it, because this is not given to the local population. So you're giving a luxury to the guest population. So these are the nuances of when you're implementing a policy at the national level and local level. And again, when you look at the resource allocation, mostly it's coming from the public health context. the public health context is mostly on the prevention area, but mental health prevention, that expertise is almost non-existent in many of the settings. I've seen refugee city, I just using the refugee setting because one of the most vulnerable population group, how they're systematically left out of access to mental health related support and services. So that's what I'm using that experience of refugees and mental health. And within that, refugee children. And the refugee children, they are witnessing violence within the camp. Violence by the police, violence by the law enforcement officers, violence by the community leaders. And at the same time, there's a perception that refugee children are living in a violent settings. Means the community's context itself is violent setting, and because they witness it. But when I closely observed, the support for them, even mental health and psychosocial support for the children, come from the community structures, not necessarily from the administrators or the program managers. But the program managers think that children are in a violent settings. So this is an interesting dynamics I noticed that the program managers, they always refer that children are exposed to violence. But the institutionalized violence is not looked upon. For example, when there is a violence in the camp, quite often what police they do is the law enforcement, they open the tear gas to disperse the crowd. But the severe impact is on the children. That's an institutionalized structured violence is not understood. So that way, we have to look at violence not only on the interpersonal violence, there are structural violence involved. And structural violence targeted towards children, which has got significant mental health related challenges. So our understanding about mental health needs need to be expanded contextually. And definitely the research plays a very significant contribution to that. And also, if you look at the training, human resource component, the trained manpower to look at the mental health support program. And the professionals themselves are experiencing stigmatization. This is one thing I noticed that the professionals who are specializing in mental health related support services, they are stigmatized. And within the professional community, quite often they're marginalized because they're considered as not so, the in thing they're doing. So this is another major factor which sometimes we overlook into that issue. The professionals also getting stigmatized. That phenomenon need to be looked upon that. So this you need to work with the professional, the peer support or the professionals involved in that, counselors, doctors, pediatricians. So even that group, if you're specializing in mental health, they get stigmatized. And the other issue is that what I'm noticing is that children's mental health is the children who are in touch with law enforcement or in conflict with the law enforcement institutions. And I had opportunity to visit some of the children's detention centers. And the children's detention centers is, in fact, it's operate within beyond the legal framework of any of this. Juvenile justice system quite often is not even applied properly into the children's detention centers and how it breeds mental health challenges of the children. This is not refugee children. These are the children who are detained. Maybe they ran away from home, not necessarily a legal issues involved, but at the same time, they're immediately getting in touch with or conflict with the law enforcement agencies. And quite often, law enforcement agencies are least sympathetic towards mental health issues, mental health related, and they're not prepared or skilled enough to identify the spectrum of mental health related issues. And this quite often, all these are classified as throwing tantrums. And then they become more aggressive again towards the children. So within the mental health, again, I emphasize on the two groups, different population groups, different subgroups of the children, including refugees and other vulnerable population groups, children in detention centers, children in conflict with legal institutions, and also increasingly elderly population. One of my study on the aging population, almost 3% of the population, their main complaint was about loneliness and being, at what stage you identify your loneliness as solitude. So that skill, whether all loneliness is a negative thing, or do you have any skill, do you have any training program to identify, understanding, utilize loneliness as a solitude, as a spiritual experience, as a learning experience, and as a self-discovery. So the new areas of looking at mental health need to be worked out, as you mentioned. Also, Asha mentioned about the knowledge building about mental health. So within that hierarchy of the needs, treatment needs is important, identify. But one thing overall when I looked at is self-care. The concept of self-care came up in the context of COVID pandemic. And the self-care is not understood very well. Self-care is not promoted very well. But maybe mental health issues, the self-care is how do you train to take care of themselves? So I think I would even say that we have to create a subdomain of self-care, not only in mental health, in the broader sense. How one could take care of themselves, and particularly in a vulnerable settings, in a disaster setting, in the refugee setting, this reminds me of the issue of the Latur earthquake about 25 years ago. The children was traumatized, their trauma was never addressed, and they grew up as young people now, and they have families, and that now they're exhibiting the stress and vulnerability and mental health issues right now when they're at their adulthood. So our understanding is even that was not expanded. When, for example, when interventions were carried out 25 years ago at the Latur earthquake, about 10,000 people died. This mental health psychosocial support for children was almost non-existent because many people thought this is a luxury. So the idea of self-care in the context of mental health literacy, maybe that's the one thing we should give a special emphasis. Are a minimum standards of self-care and also training on what is self-care and how to take care of it, and minimum essential life skill for a self-care. And this is one thing I noticed, that a lack of emphasis, lack of skills in self-care. And this issue came up very prominently in the context of a COVID pandemic. And COVID pandemic, we know that is inducing mental health in a very phenomenal way. But at the same time, what is a better intervention in the confined settings? Because they are in a confined setting, we have no escape from the four walls of the domestic settings. But how do we do, and what intervention will do, who will intervene, and what is the scope of intervention through the online interventions? And online intervention without making any changes in the relationship context, within the family, within the domestic setting, the relationship dynamics is set in. And we don't have the skills or expertise to do that changes in the relationships through an intervention on a Zoom intervention. So we don't have the tools to deal with it. Or we haven't thought through a research process to identify what are the intervention strategies in the context of COVID pandemic lockdown. So these are some of my random thoughts about evolving opportunities and also evolving threats and challenges about mental health in broader sense, and the need for creating and revising mental health policies, and also promoting mental health literacy in the broader context. As you mentioned, literacy is not about just literacies. Probably we have to even think about a new conceptualization to explain what you meant by mental health literacy, because mental health literacy concept is not understand, we are not doing justice towards what we're trying to do. So maybe, I don't know, mental health empowerment program, maybe, we have to think about, it's a term, sales skill, maybe the concept of mental health literacy, we have to relook at it, because it's not explaining the situation, what we're trying to do. It is not giving a kind of a therapeutic explanation, not even not diagnostic contribution, no knowledge creation basis. So probably we should have a relook at and reimagining the concept of mental health literacy from a broader context of self-care, diagnosis, and ongoing support program, treatment, self-treatment, and also professional support, and also seeking care and seeking support. So all this collectively, how do we call it? So maybe that's another challenge, and I'll leave it with that challenge. Thank you.
Yeah, I think that's great. Thank you very much. I think you touched on some of the key points, not just that is actually facing India in the global north as well. In some of the Western countries, we have exactly the same kind of issues in relation to how do people own up to promoting that well-being, and that self-care. Self-care is actually the first step in relation to understanding both, not just in terms of mental health, and also the kind of health literacy. If we have good health literacy, then people are much more aware of those things. And I think India, as from the history and from the heritage, and know there are a number of skills, a number of resources that India has in terms of that welfare, self-care, and promoting that for the well-being, really. You also mentioned about loneliness and social isolation, and not just for the older generation, but also the kind of how loneliness and social isolation may have actually impacted on all of us because of the COVID pandemic, and how it may have tilted a bit about how we think about our own well-being as well. It may have acted in a way that we have to think about our own well-being and how we actually take steps to actually promote that well-being. Because I think it is important that we can the resources that all of us may actually have those resources in terms of creating that well-being and that happiness and that mental health. But I think, and also when to seek help and how to seek help. And I think that is very important to actually have that knowledge, as you touched on earlier on, in terms of young people and their families, and what is their understanding about mental health, and what is it is important that we mainstream that conversation around mental health and well-being, which is what we are actually trying to do in these webinars, in terms of it is okay to talk about it. It is okay to be not okay. And I think it's important to try and actually emphasize that point from time and time again, and trying to kind of, get out of this destigmatizing mode, and how we try and promote that well-being. Because I think these days it seems to be that, if you have cancer or if you have heart disease, it seems to be very fashionable, or it seems to be very seductive. We're actually looking at it. Sorry for putting it in that way, but I think that's how it is actually looked on. Whereas the media and everybody else actually portrays mental illness from a very different perspective. And I think the media have got a major role to play as well in terms of how we promote mental health literacy, and better and accurate understanding of what is mental health literacy and what is mental health and well-being as well. So I'll take a point from Professor Asha as well before we go into the questions.
Yes. So is it from the Q&A?
Yeah.
So how do we push for an increased budgetary allocation for mental health services? We keep saying, if at all we have to say, it's like advocacy initiatives, again, building evidence and, lobbying, all of that. But then at the same time, I would also say that how are we becoming efficient in utilizing the existing services as well? Because that's what we are also talking about. How do we do intersectoral collaboration? How do we promote multi-sectoral collaboration? Like, for example, there is education sector. There is a dedicated budget for education. However insufficient it is, we have lots of schools. How do we build mental health models? How do we envisage workplace mental health, but not in a very tokenistic way, but again, very sincerely strategized and contextualized for. So we have to really look, and intersectoral is how, all the general hospitals are also equipped in handling psychiatric emergencies. So somewhere we are also thinking of becoming very resource efficient. At the same time, building evidence that dedicated funding for mental health services is important, because as Professor Joe mentioned, it's not even a national obligation, it's a global obligation. SDG 3 clearly claims that promoting mental well-being is important. So there are avenues, but then how do we really work on it? What is the kind of commitment we also keep, for the ashram school, that's the Tribal Development Board school where we work. We are just using skills as the frame, but then the mental health is embedded into that skills program. So in 3 years, we see a change. And it is not only the children, even one of the teachers who approached us said that the way I see a child, the perspective has changed. That transformation is important more than, more than in terms of, I don't know how to put it, but then the transformation. I do not use a stick. The moment I see a child, I see the child with a different perspective. And that is what is important. And that kind of transformatory research becomes critical. So this is what I want to put. We have to be very resource efficient. Now, this school model can be replicated. Now, you can say this is a resource efficient, it's an embedded model, and how it can be replicated across resource poor contexts and schools.
Yes. So anything anything to add on from the budgetary perspective, the budgetary allocation, Professor Thomas? Any more to add on to the question in relation to how do we push for an increased budgetary allocation for mental health services?
Is it to me or?
Are you able to, did you hear the question?
This question is to Asha or to me?
Yeah, I think it's we talked about that. I think from your perspective, can you add on? Is there anything else to add on to that?
Okay, let me just attempt to give an answer to this. Budget allocation for mental health, one of the best strategies, I look at the disease burden and the opportunity cost of not having intervention. So probably that is the best advocacy component for that. And we have to compute what is the cost of treatment and what is the cost of opportunity cost. And within the opportunity cost, we have to look at the potential contribution of the people who are mental health issues are avoided. So there are lack of investment, and also investment can lead towards better health and well-being. Better health and well-being means better contribution, because persons with better health and well-being, they are the best infrastructure for national development or social development. So we should have a different discourse on the value of interventions for reducing mental health related burden and the disease burden. We can compute it on a quantifiable terms, because most of the budget allocation, budget advocacy, we have to present it in a quantifiable numbers. So intervention for reducing mental health, and also, for example, how many suicide is averted. You can immediately calculate it, that the young people, their potential contribution to society can be computed. So this is the one way to deal with it. And second, we have to get the endorsement of the opinion makers in the society. Then some of the senior community members, those who experience mental health issues, maybe they are from the religious leadership or cultural leadership, those who experience mental health issues, mental health related challenges, then they stand up and say that, this is my experience. This should lessen the stigma as well as contribute in advocacy towards better resource allocation. So this is then of course we have to go back to our solid classical research and the data and evidence for investment or for investing in mental health. So this is the few immediate response I can think about.
Okay, thank you very much for that. I think you mentioned about the disease burden. I think it's important how the days lost in terms of our work and the kind of other productivity and all those things that actually counted. It is not just the diagnosis and illness that actually counts as well. The number of days that people are actually off sick from work because of any smaller distress or whatever, all those things actually counts in terms of the productivity of a country and also the well-being of a country. So I think it is. I think it's, and I'm trying to kind of connect it to an earlier point that you actually made in terms of how we connect the whole idea of mental health and well-being to the primary care. Because I think the primary care initiative should be actually focusing much on the mental health initiatives as well. Because obviously there are many advantages of that. It is easily accessible. It is not that stigmatic because you're not actually going to see a psychiatrist or a psychologist. You're actually going to see a general practitioner in relation to that. So, and I think there are advantages, and also there's immediate help and support, really, and also there can be an agent or facilitator for some of those mental health literacy programs as well within the local communities. So I think the kind of primary care interface and how that can actually play a crucial role, and how we evaluate that. Some of those things in terms of the outcomes and some of the things that you mentioned in terms of suicidal rates, in terms of the well-being, in terms of the happiness index, in terms of the wellness index, and all those things might actually contribute to those processes. So and I think it is vital that we try and pitch at that context as well. I think in some of the rural and tribal communities that we know from our own study, there are kind of immense, great work being done, some of the NGOs in relation to how they actually integrate that healthcare into those tribal communities. And I think so it's important that that's actually looked upon from a pan-India and also from very much from an urban perspective as well. I think this, I think we should actually have the kind of because people often only talk about the kind of health policy and also mental health policy. We mainly talk about interventions. We don't talk about prevention. We don't talk about awareness and self-care, as you rightly said. And I think it is how we actually try and pitch on that mode in terms of prevention is the first step. Prevention, awareness, and I think that literacy is the first step. And I think the intervention is the second or third step in relation to if you are actually unwell at a later time, and then you actually seek the intervention. But I think it seems to be that, in the global South, I think there is a lesson to be learned from in the global South, but because the global North actually turned the intervention as the first step and prevention as the second step. And I think there is something that the global South may have to be contributing, because there it is still prevention in the first step and intervention is the second step. And I think that maybe it is important that we learn from that exercise and not to actually turn upside down and say that intervention is the first step. That actually results in medicalizing the whole idea of health and well-being, and also mental health as well, really, because there is much more that we know in terms of self-care and how self-care and knowledge and attitudes and practices can actually promote good health and well-being, which should be the first motive, which, as you rightly said, in terms of our policies. Any other questions? And I think just looking at the questions, I think we're still looking at that they're still interested in the budget reallocation. If you have any other questions, do put that onto the question and answer box, please, or on the chat box, whichever you prefer. So we will continue the conversation. And I think you mentioned earlier on, about the kind of family and violence and conflict and violence-ridden societies, really. So I think it's important to actually focus on that. There was something that came up on the chat box. So what can be the steps we can take as school counselors to promote mental health advocacy amongst children? I think Asha touched on it, but you may want to expand on it.
So I remember one of our alumni, she created a very school-specific model. It's a private school, and she called it as Reach Out. And what was done in that particular module, it was co-constructed with children. What are some of the specific concerns of that school children? At times, we may miss out on certain components. So it was co-constructed along with high school students, and there was a manual, and it became like a self-help book. And also minimizing on stigma, because they started with how, they also start with a video documentary to say how a child hesitates. Oh, I am a boy. If I knock at the school counselor's door, what the others will think. It's also connected to how macho you are a bold type, what others will think when I see. So it started with stigma to moving towards co-constructing manual with the high school students, and that way build an impetus for school mental health program within that particular school. So it's very important to talk to the children. It should not be like our understanding, but also what bothers them. Series of consultations with them. And then building an agenda in consultation with them, there is adherence, there is less stigma, and people become advocates for themselves. So otherwise, it's always like, I am vulnerable. Can I meet the counselor? Not meet the counselor. You move from that position to, okay, it happens. It happens to everyone. I need it today, and others may need it tomorrow. You move from that one level of vulnerability to agency building. That's very important, and that can happen only with consulting with children. So I think consultation is very important.
Okay. Thank you for that, Professor Thomas. Can you add on to any other further points that in terms of how can school counselors promote mental health advocacy amongst children?
To begin with, you should have mental health counselor in the school. And so that's my immediate statement about it. And probably we should have a proper program to understand how to promote mental health literacy in the school. And that should be a mandatory requirement. And particularly when, say, for example, one of the indicators like, the suicide rate goes above a certain level, then it should be mandatory that there should be a student council looking at promoting mental health literacy as a mandatory policy framework. If any community, any school, if the suicide rate goes above a certain level, and there is no negotiation at all, that there should be mandatory resource allocation. So this would be within the national policy framework. You could bring in that kind of a separate loop to ensure that the mental health literacy programs are being implemented. And that definitely link up with the issues of substance abuse, issues of attempted towards committing suicide. And also, I would say that the prevalence of bullying in the schools, because bullying is a mental health issue. And the children trying to cope with the bullying is also as a victim of the violence. So, I mean, we may have to create certain mandatory indicators to, from the policy perspective, certain policy initiation should set in as a preventive program. For example, mandatory mental health literacy program, when X, Y, Z issues, the variables, indicators are crossing certain threshold. So this is one way to mandatory intervention can set in the educational setting. Because right now, I would say that very microscopic minority of the schools, I'm talking about the public schools and I mean government-funded schools, the intervention in the area of mental health and psychosocial support program. But the national policy should have a circuit breaker within the policy framework. For example, they should say in any settings, if the mental health, the attempted suicide goes above certain level, it's mandatory. That school system should come out with mental health awareness program, or they should have a counselor. So these are some of the policy short circuit to make sure that the interventions are in place, and particularly prevention as well as the treatment interventions.
Yeah, thank you very much for that. It's very, very important point. We have another question.
So that was what in my thought as well. When I read that question, I thought, first of all, funding for school counselors, and they should be well paid. Otherwise, school counselors are paid 8,000 rupees. So it starts from there. But then I looked at it and I thought, okay, somebody is a counselor and asking a question. But that's a nice response. We should have school counselors in the first place. So, yes.
Thank you. I think we have another model, I think, from Sanjana Kumar. She talks about an oral health drives promoting brushing one's teeth and 6 monthly checkups. And how would a self-help mental health model mean the Indian context, and how we can actually define that? A very important question, a very apt question itself, because obviously this is actually we're talking about primary care, prevention, etc. How do we have a self-care checkup on a 6 monthly basis? Do we have an instrument? I think there are a lot of instruments that we can actually use within the context of how we keep our well-being. Any quick points from you, Asha, Professor Thomas?
I would say there is nothing like a ready-made response, because that self in itself is so elusive. What suits me may not be suiting another child. What the setting also is. But then a school-based indicator can be set up. But Sanjana, that's a very tricky question.
Yeah, very important question too. Yes, it's very important. How do we do that? Because it's part of the primary prevention stuff. Dentists are very good at that in terms of primary prevention. Professor Thomas?
I would look at self-care as an important initiative in the context of a self-awareness and self-actualization and also self-empowerment. And what the scientists can create is that we can have a rapid checklist. What is your level of self-care? And a multi-dimensional self-care, that is mental health, could be one of the major part of it. And the physical care also comes in. I would suggest care on a multi-dimensional context, prevention, care, treatment, support, health-seeking behavior. All this composite, we can create maybe a checklist or a protocol for self-assessment about self-care. Maybe I'm too ambitious. Self-care protocol, or a self-care checklist, or a self-care. You can have a checklist on are you ready for the self-care today? So
Yeah.
10 questions to see that whether you're ready for a self-care, or do you need a self-care? What level of intervention you need? But one thing I'm getting more convinced about the need for promoting on the policy framework, promoting self-care. And this is not necessarily medical care, but to understand when to seek medical care and what kind of medical care. For example, now this kind of decision is taken care. I mean, we have subjected to many times. For example, for what diseases we'll go for Ayurvedic treatment, for what disease we'll go allopathic treatment, for what diseases, for which community, which population groups we take them to this homeopathic treatment. So this all actually a segment of our understanding about self-care. What care, where do you seek the care? And a health-seeking behavior could be refined through a self-care approach. And it could be taught, it could be self-learned, and it could be part of, for example, we promote yoga and we promote, mental health related initiative. So probably this also could be self-care. I mean, maybe we could think about a self-care training program, self-care. I mean, as an academician, I put a cap in a diploma and certificate course. But beyond that, probably we should have some kind of community-based, voluntary-based, a kind of effort towards promoting self-care. Yeah, and that could be an extension of the primary care. It should be an extension of the community care, and it should be extension of specialized, health-seeking behavior promotion. So anyway, I emphasize that we should need a relook at the issue of self-care.
Yeah, thank you. Yeah, I think that's an important point. I think self-actualization is not just for Maslow, it's for all of us. So I think often self-actualization is only associated with Maslow, but I think we all need to be self-actualizing ourselves in terms of things. Right. Another question.
I just want to add here, when I said we can, I don't know, somewhere that protocolizing is very difficult for me. But then at the same time, the same project which I was talking about, we are looking at this. We are looking at connection. We are looking at engagement. And we are looking at, a healthy identity formation. Because we are aware this was for schools, the kind of identity-related concerns also. And in a way, when I said skills, we can actually see how we've built agency over a few months. The students also engage in physical exercises. And also there is something in the form of skills called organic farming. That means they connect to the soil. The organic farming also, they cultivate green, freshy vegetables, which goes back into their midday meals. So somewhere you're looking at nutrition. And then we also have other forms like yoga. So every day the children get up and they participate in yoga. So somewhere the nutrition is taken care of, physical fitness is taken care of. They are learning a particular skill. And also we are looking at gender equity. So how girls and boys work together as a team doing carpentry. How they have created an ambience in the school, repairing the old furnitures and creating their own cupboards and library. So somewhere you can see that ambience, the shift in the ambience and their engagement. So it is all very much interrelated. So I'm like, yes, academician, also a practitioner's hat. So I find it that how to protocolize that in the way like once in 6 months, but I see over the 2 years of engagement on several parameters you can see. And also one of the points you mentioned about bullying has long-term impact. And so somewhere while engaging on these skills, bullying also comes down, because bullying, or the people who not only getting bullied, but the bullies also have some concerns. Now when you address that, then there is transition there as well. So that's something I wanted to add.
Yeah, I think that's very important. Yeah, we have a couple more questions. Postpartum depression is very common nowadays, and shall maternal mental health counseling be taken as compulsory measure? And what's the panel's perspective on that? Who want to start? Professor Thomas?
Maybe I could add a few more things to that list. And I would say that, for example, if you look at the mental health and nutritional deficiency, nutrition imbalance and its impact on mental health, and you should understand that almost 50% of the Indian children are malnourished at various stages, various levels of malnourishment. So maybe malnourishment and lack of nutrition as a contributing factor towards mental health issues, mental health challenges. And that, even I looked at the data, with not very much data on that issue, linking it with what are the nutritional interventions required for looking at the mental health, mental well-being. So this is also could be linked with the national broader policy framework, because we have a nutrition promotion national Posha Abhiyan program. But within that, maybe we had to create sub-component on various aspects. It should be part of the national health policy, national mental health policy, national elderly policy, national nutrition policy, national women and children policy. So like the interim policy coherence, also looking at, you had to look at how mental health is becoming a kind of a transdisciplinary intersectionality of the mental health in various other policy framework, which is also we haven't looked at from the policy perspective, research perspective, and also, prevention intervention perspective. So, our concerns can be expanded a little further. For example, what are the short-term interventions for reducing nutritional imbalance and its implication for mental health? I'm just giving an example about it. And also you mentioned about the antenatal mother's depression. And to what extent is it linked with the nutritional balance? It is with the changing social status or changing social roles and adaptation and capacity to cope with it, or also just the changing roles and its pressure on the mothers. So like that, is coming up. And also the technology, diagnostic technology, what we have for the mental health issues, whether we have any real technology-based intervention. For example, we have mobile phones are very, smartphones are very active, but can we create apps to check up whether your mental well-being is minimum standards is reaching? So maybe that's another area. And also your experiment with the art form is another method, but technology, maybe can we invoke the skill of artificial intelligence to look at mental health? So these are some of the questions remain to be asked, or put it in our list of a wish list of mental health intervention or prevention opportunities. Thank you.
Yeah. Professor Asha, any?
It's very important. That's what I said. Intersectoral is very important when perinatal depression is acknowledged, documented, and why it should not be integrated.
Yeah.
And somewhere deliveries are institutionalized. People go to PHCs nowadays. So I think it should be very important.
Yeah. I think there is also a point that need to be made here, that in terms of our in a cultural heritage, because of the society have changed. Obviously, the paternal, maternal mental health and other things, whether there used to be collective as a family, people looked after, but now that is not possible. And the kind of some of the traditions are not actually passed on. In the how life has become more modernized, and modernization becomes more medicalization, and medicalization becomes super medicalization, and all those things. Actually, we are trying to actually attach everything to a kind of an illness mode. Because I think we need to have a label, we need to have a diagnosis for everything these days. And I think some of it's actually going back to the kind of self-care mode as to how some of that could be actually achieved as well. So thank you for that. And one final question, I think we have a few minutes. Kavita Nair talked about the dearth of mental health professionals, just 898 clinical psychologists and 3,800 psychiatrists are available, and entirely of India's population of mental health conditions. Yes, that point has been made from time and time again, both in terms of policy dimensions and also in terms of service gaps, lack of trained professionals who would be able to help the situation. So how do can we ask our panelists as how that is being addressed in the Indian context? Professor Thomas?
I just go back to another statement you made, and we have a national heritage to deal with mental health. For example, we assume that extended family is a better support for mental health. But if you look at some of the data coming up, many of the youngsters, they feel that they constrain their possibility to explore, and that their innovation and exploration capacity is restrained by the the traditional, the pull factor of their resilience and also moving forward. I mean, I'm just putting it in a very layman's language. So our resolve to go back and look at cultural heritage also comes with certain level of danger. And is it contributing towards our progress, or it's restraining our innovations and our capacity to explore? So this is one of the major issues. Many of them in joint families or extended families, they act as a kind of a barrier towards the young person's exploration or desire to explore, desire to look into different possibilities. And also they desire to establish a relationship that is severely restricted, saying that in the context of heritage and family pride. So this is one of the tricky proposition. There are certain elements like community support, extended support, but that extended support also could come as extended restrictions. For example, girls' mobility, girls' exploration, girls' self-actualization, and even the boys and how boys should behave is as a traditional macho man. So that comes from your cultural milieu. So that way, I would look at a little more. It's a push and pull, or it's a conflict between progression and modernity and the tradition, and in that creates additional pressure on the young people, particularly on young people. And elderly also face this dilemma, and because they get frustrated because the young people are not following the social norms and traditional norms, and that gives anxiety, stress for the elderly population. I'll just give an example and then stop it. And I did a study on the elderly population, their well-being, health and well-being. And we had a call for a meeting to discuss about the findings of the elderly study. And then I was looking at the issue of violence, fear of violence, loneliness, access to treatment, all these issues. And then I asked some of the senior people who were part of this, I asked them to respond to that. And one elderly person stood up and said, the biggest problem we are facing is that young girls are becoming lawless and they have no respect to elderly people. When we get into the public transport, they don't get up and give us a seat. So when the girls were saying that we are also equally tired, I was sitting in, and one person said, get up and give me, I was really tired. I was sick that day, so I sat. An elderly person came and demanded that he is reasonably well-built. And he said, get up, I'm an elderly person. So this expectation between the intergenerational expectation can lead towards mental health challenges, and particularly elderly population, they get frustrated because when they see that they are not respected, they expect certain social status, which the elderly young people may not care much about it. So this issue also may be an intergenerational stress is contribution towards mental health issues. So probably that also an area which we have to look into, that our wish list we look at the remaining agenda, maybe I would say.
Yeah, certainly I agree. I think that there is that intergenerational tensions as well, but I think there are kind of good things as well from it in terms of, so I think we shouldn't throw the baby with the bathwater. I think we should take the good things from it, and also some of the ancient traditions that were not so progressive in terms of our outlook, and I think that we have to understand. But I think it's just how we blend the whole thing in the kind of the cultural context, really. But in terms of the question in relation to mental health professionals, the shortage of mental health professionals within the Indian context, how is the policy addressing that? Any comments on that?
Last week, Government of India, there is a new policy came out, health and allied professionals. So, and you could independently register yourself as a counselor with this new body they created. And probably that may lead towards a better quality of our professionalism, because this is something new came up, and it came up out of blue. There is not much of a consultation about what is the scope of this allied professionals and who falls into the allied professional, and to what level of regulatory, self-regulatory mechanism, because this is a kind of an accreditation agency or regulatory agency. One way those regulations contribute positively, for example, what are the minimum level of training for the mental health professional? And they can have a professional body which monitor their professionalism and accountability. So that way, we need to have a minimum standards of care, minimum standards of professionalism, and ongoing mechanism for ensuring that ongoing skill development is taking place, and also maybe the regulatory mechanism to regulate the profession, mental health profession, and what mental health skills falls into the mental health profession. Counselors, psychiatrists, psychologists, and also para-professional level involvement, to what extent this can be led to maybe diagnostic treatment or maybe support services. All this spectrum of professionalism could be more streamlined. So there's a need for streamlining it, and also looking at the training needs a little more carefully. What's the minimum required skill set for a counselor or a psychiatrist, a psychologist, and also a long-term care, institutionalized care for mental health issues. So all this could be brought into a regulatory framework and a professional accreditation framework. So this is one of the urgent need and important need also, that this also includes the professionals, the payment issue, and their long-term career growth all need to be cumulatively looked into.
Okay, thank you. Thank you for that. I think, and also in terms of how we train our general practitioners in terms of mental health and well-being as well as part of that too. Professor Asha, can you any comments from you in relation to the profession?
Yeah, actually, Dr. Vikram Patel also has spoken about task shifting. So it's very important when we talk about mental health professionals. Are we talking about only psychiatrists and psychologists, or it is broad-based like paraprofessionals, allied professionals? Are we looking at? And also, Dr. Patel in his argument clearly said task shifting is very important. Like Asha workers are the first line of contact for public health programs. Can there be task shifting? So there are several organizations who are running, mental health nursing program where people are in the rural context. There are several paraprofessionals working in rural context. So do we want to even count them? And that way can be built in cadre at different levels. So it's not like, only psychiatrists from, district level, state level, but then also at the grassroots level, what are the kind of different cadres of professionals we can create? If time permits, I can say only one of the Asha worker trained by a renowned rural health model in Maharashtra. That's a very profound statement, because she said in one of the international, convention that doctors are like the expensive chandeliers, but I am like a diya. So you also have to look at resource. So she literally said, they can be chandeliers, but they're not comparable. But then I am like a diya, I can lit another diya, so I can be everywhere. So that's the difference between. So somewhere we have to look in terms of how do we create cadres of professionals, and also how psychiatrists help in building capacities and monitor, supervise. What is appropriate care that can be provided by different cadres of professionals? That becomes very important.
Yeah, thank you very much for that. I think we have to stop there, unfortunately, because in terms of the time span, I think the discussion is actually encouraging. There are a lot of points, and I can there are a number of different things, webinars that has actually come out of this particular discussion alone. So thank you for the audience participation, and thank you for the conversations around mental health and well-being. And my special thanks to Professor Joe Thomas and Professor Asha Banu for pitching the conversations and also giving it much broader way of actually how we can actually look at it, innumerable ways, different pathways, different ways of actually how we can actually promote this. And I'm sure I'll be coming back to you again to take this conversation to the next level in terms of how we can actually promote that in the longer term. And also my special thanks to Parvati, our digital consultants, for hosting this webinar. And thank you very much. And until next time, I think we have the next webinar sometime in 16th or 17th of April, where we are actually looking at maternal mental health, perinatal mental health. So obviously that's something to look forward to. Many thanks, Professor Thomas and Professor Asha, and everybody. Have a good Easter, have a good Easter break, and enjoy life as far as you can. Bye-bye.
Thank you. It's a pleasure. Thank you very much.
Bye-bye. Thank you. Namaste.
Thank you. Thank you. Bye-bye.